An elite runner suddenly doubles over mid-stride with severe stomach pain. Across town, an office worker sits paralyzed by tension headaches and extreme digestive bloating. Standard medical protocols treat these overlapping issues in isolation. A gastroenterologist addresses the stomach symptoms, while a physical therapist separately works on the tight muscles. That approach relies on a disconnect in how we view human anatomy. We treat metabolism and the muscular system as entirely separate physiological networks. But look at the anatomy in this high-contrast illustration. With the skin and muscle removed, we see the fascial nets. Fascial nets are continuous, structural webs of connective tissue that wrap and integrate the entire body. When we measure blood chemistry alongside physical tension, a distinct pattern emerges. Metabolic markers don't just circulate, they concentrate within specific fascial lines, creating a physical map of internal distress. This means to resolve a chemical or metabolic imbalance, practitioners must physically release the structural tissue it is concentrated within. This transparent 3D model of the human body serves as our diagnostic canvas, mapping exactly where internal chemical failures structurally manifest. When a patient presents with chronic low warmth, slow digestion, constipation, and extreme physical fatigue, their data points cluster around the core and extremities. This is a hypostate, specifically a cold-fatigued or freeze-collapse pattern. Tracing these localized collapse symptoms inward reveals their structural anchor, the deep front line, or DFL. The DFL is a dense central structural pathway running directly through the deep core of the body. Releasing this restriction requires a precise clinical intervention spanning the produce and regulate phases. Practitioners introduce internal warmth, load early carbohydrates or warm soft meals, and guide breath expansion to restore the core pathway. Chronic fatigue and physical freeze states cannot be stretched away. They demand simultaneous metabolic warming paired with deep core fascial release. Our model resets to show a different physiological profile, the hyperstate. Here, urgent hunger, shallow breath, loose stool, and high physical tension localize around the ribcage and periphery. These high arousal symptoms map onto two external culprits, the spiral line and the lateral line. These fascial networks act like mechanical binders, wrapping and compressing the exterior of the torso. If a patient is inflamed wired, experiencing bloating and irritability, the restriction sits in the spiral line. The intervention happens in the regulate phase by reducing physical load, introducing grounding fats, and mechanically decompressing the twisting tissue. Conversely, if the state is stress-dominant flight, the lateral line takes priority. The sense phase requires an infusion of electrolytes, fast carbohydrates, and targeted rib expansion to release the sides of the torso. Treating acute anxiety and physical stress requires decompressing the wrapping connective tissues that are physically suffocating the nervous system. The model resets again to map peak physical exertion, showing mechanical stress points layered squarely over the stomach and GI area. This represents athletes experiencing sudden gastrointestinal distress during training, followed by total failure of physical recovery. This athlete overload state maps directly onto the superficial front line, or SFL. The SFL is a continuous superficial layer of connective tissue running down the entire front surface of the body. Breaking this specific mechanical failure loop requires the process phase. Practitioners execute low-load fuel ladders and precise hydration rhythms to systematically restore the capacity of the superficial tissue. When this anterior network is under tension, it interferes with the rhythm of digestion and hydration. What looks like an athletic plateau is actually a structural manifestation of broken metabolic processing. Looking at the fully illuminated model, we see the deep front line, the wrapping spiral and lateral lines, and the superficial front line, all operating as a unified web. Treating dietetics and physical therapy as unrelated sciences is a medically obsolete approach. A patient cannot out-eat a physical fascial restriction, and they cannot stretch away a deep nutritional deficit. The ultimate clinical repair protocol requires practitioners to first diagnose the precise metabolic pattern cluster and then concurrently treat its exact fascial net partner. The human body is a single living web. True healing demands addressing the physical lines that connect our chemistry to our structure.